Good morning, everyone. I'm Dr. Asif Sardar. Today, I'm going to talk about SLE and pregnancy. So, today's learning objectives will be when to suspect SLE and how to identify the common clinical presentations of SLE and the considerations of and outcomes in pregnancy and the basic concepts of management of SLE in pregnancy. So, SLE is basically a chronic autoimmune disease which affects eventually most of all any organ of the body, and there are immunological abnormalities and there are multiple antibodies which are positive, and it can range from mild disease to severe life-threatening disease. So, SLE is usually the prevalence is 20 to 150 cases per 100,000, and it's most common in African American individuals. Mostly in the children, the female to male ratio is 3:1, and women of childbearing age, its ratio is 7.1 to 15:1. It can also involve the older individuals, especially postmenopausal women, and 65% of the patients who are having this disease aged between 16 to 55 years. So this is the pictorial presentation of few of the clinical symptoms of the SLE. It involves all the organs of the body. So it starts from the brain, and it can cause some psychological abnormalities, some systemic abnormalities like low-grade fever and skin manifestations, oral ulcers. It can involve muscle with the muscle pains. It can mostly involve the joints, and it can involve the kidney, pericardium, pleura. If you talk about any organ, the SLE can involve that. Uh, Few of the associated conditions and complications with the SLE in women, this antiphospholipid antibody syndrome, which is very common with the SLE, and it's the most common cause of abortions in the women. And osteoporosis, which is most, and osteonecrosis, which is mostly related to the treatment options which we are using in the SLE. And fibromyalgia is very common in SLE patients, certain infections, and another autoimmune disease. So basically, the diagnosis of the SLE involves the clinical symptoms and the lab test. Lab test involves basically the detection of autoantibodies. Uh, ANA should be positive when we are suspecting a patient having SLE. The ANA is a must in the criteria. I will later on explain the criteria. So this is the 2019 American College of Rheumatology criteria, and it has sensitivity of 96% and specificity of 93%. So it states that the ANA should be positive 1:80 ratio in any patient we are suspecting SLE. With that, the other clinical manifestations should be there. So this is the criteria which includes the clinical manifestations. It includes the domain and the manifestations. So if we talk about constitutional, the fever comes with the 2 points, and the cutaneous manifestations include alopecia, oral ulcers, and arthritis. Arthritis should involve at least two or more joints with synovitis, and the morning stiffness should be there for more than 30 minutes. Neurological include delirium, psychosis, seizures, then serositis involving pleura or pericardium or pericarditis, then certain hematological abnormalities like leukopenia, thrombocytopenia, autoimmune hemolysis is common in SLE. And then the most common, the most important, the renal involvement, which include proteinuria or the lupus nephritis. Then antiphospholipid, the antibodies, then there comes the lab manifestation, antiphospholipid antibodies, complement levels, and the highly specific antibodies in SLE are anti-dsDNA and anti-Smith. Now, the important things about this criteria, like if a person is having, from each domain, we will count only one symptom towards the final weightage in the criteria. So if a person is having, for example, alopecia and oral ulcers, and there is subcutaneous or discoid lupus, then from all these three, we will count only one towards the final criteria, the one who is having highest points. Like if person is having all these three, we will count only subcutaneous and discoid lupus with the points of 4. So each domain we have to pick the one with the highest rated points towards the final criteria. And total, a person having ANA positive with 10 points we can say that he's having SLE. So now we'll talk about the lupus pregnancy, and the risk of morbidity and mortality is very high. It's about 20 times greater in SLE, pregnant women with SLE as compared to the healthy women. So the pregnancy is usually discouraged in the presence of uncontrolled disease. So the pregnancy should be planned when the disease is inactive for at least 6 months. Conception in SLE patients is also challenging because of the certain autoantibodies profile and other comorbidity and the presence of certain medications which cause ovarian failure. So these are the factors affecting the conception. It includes if the patient is having severe flares with secondary amenorrhea, if she is having chronic kidney disease with GFR less than 60, or drug-induced ovarian failure. I talked about this. Cyclophosphamide is the one causing drug-induced ovarian failure. And if a patient is having venous thromboembolism, or women with ovarian hyperstimulation syndrome, or she has some prothrombotic risk factors. So the risk factors for poor pregnancy outcomes are high disease index, the conception in the presence of active disease, renal impairment or presence of active lupus nephritis, very low serum complement levels, and high dsDNA levels, which denotes the presence of active disease, and a person having active lupus nephritis, presence of anti-Rho antibodies or antiphospholipid antibodies, or systemic hypertension, Raynaud phenomena. These are the all poor risk factors for pregnancy outcomes. Now, few of the maternal complications which a mother can have if she has SLE. So the maternal complications are usually 2 to 4-fold more in the lupus pregnancy. It includes preeclampsia, 16 to 30%, and eclampsia. There can be spontaneous abortion in up to 20% of cases, thromboembolic illness, maternal hypertension, premature births, which is the highest, 15 to 50%, then postpartum infection, hypothyroidism, and stroke. Then these are the fetal complications. It include structural myocardial complications. That includes the heart block. Then fetal growth restriction can be there. Neonatal lupus in the presence of anti-Rho and anti-La positivity, and fetal loss is 8 to 20%. So basically, when we plan pregnancy in SLE patients, it should be proper with the proper planning. It starts with the pre-pregnancy measures and goes up to the postpartum. So it starts with the preconception counseling. The preconception counseling basically should involve obstetrician, rheumatologist, and the patient. So there should be a multicentric approach, a multidisciplinary team meeting should be there, and all the outcomes and the risk factors and everything should be explained to the patient before the pregnancy. So then there should be assessment of clinical and laboratory indices in the patient. We should check the presence of active disease, any organ damage, or any comorbidities present. I spoke earlier that minimum of 6 months of disease inactivity should be there before conception, and cardiovascular health should be good in the patient. And we should the safe continuation of teratogenic drugs, because if a patient is already on teratogenic drugs, it should be discontinued before conception. Then ideally, pregnancy should be avoided in the presence of severe end organ damage, like if there is pulmonary hypertension, severe restrictive lung disease, recent CVAs, or prior pregnancy with severe preeclampsia, eclampsia, or HELP syndrome. So the pregnancy should be avoided in these cases, ideally. And pre-pregnancy, the following laboratory indices should be done. It include autoantibody profile, including anti-Rho, anti-La, anti-thyroid antibodies, lupus anticoagulant to detect antiphospholipid antibody syndrome, and then anti-RNP. And there should be check of serum complement levels. These are very important, the serum complement levels, because it later on will help us if a person is having flare during pregnancy. The flare of SLE in pregnancy can mimic the symptoms of pregnancy. So if we check the complement levels before pregnancy, it will give us baseline levels of complements. Because during pregnancy, the complement levels in the normal pregnancy usually rises. And if a person is having SLE during pregnancy, then instead of rising levels of complements, they start decreasing. So basically the trend of complement levels will help us to detect whether it's pregnancy symptoms or the SLE flare. Then during pregnancy, the monitoring should be done, and it should be with the clinical and laboratory indices. If a patient is having antiphospholipid profile positivity, then straight away she should be started on low dose aspirin with low molecular weight heparin. Then if she has hypertension, that should be managed as per OBS guideline. And we should look for the adverse maternal outcomes. The predictors we should look for are hypertension, thromboembolic manifestations, worsening of renal functions during pregnancy, presence of preeclampsia, eclampsia, HELLP syndrome, or if the autoantibody titers are rising during pregnancy. Uh, for follow-up then we should also look for the predictors of adverse outcomes for the fetus. It includes IUGR, fetal heart blocks, or stillbirths, which are the complications. We should look for that also. Fetal ultrasonogram should be done every month in SLE patient, pregnant SLE patients. And echocardiography should be started from 16 week of gestation to detect any presence of any structural heart abnormality or heart block. Then we should monitor and assess for the severity of flare, and we should be able to differentiate between the primary disease and the flare complications, or the complications only primarily related to the pregnancy. Mild disease during pregnancy can be safely treated with low dose steroids, hydroxychloroquine, and azathioprine. And moderate to severe flare without the treatment should of the moderate to severe flare with or without major organ involvement should be done. The low dose steroid, hydroxychloroquine, or azathioprine can be used safely, and later on I will discuss the other treatment options. Uh, Now the disease, if there is some life-threatening condition happens during the pregnancy, then the decision to terminate should depend on the severity of flare and response of the implemented strategy. And during the postpartum period, the patient should be monitored for any postnatal complication like bleeding, sepsis, any thromboembolism, or any flare of the disease or progression of the organ involvement like lupus nephritis. And then assessment of the fetal complications should be done postnatal. It includes heart block or presence of neonatal lupus. Uh, then the breastfeeding, I will later on discuss about the breastfeeding, like is it safe or no in the SLE women with breast. So during pregnancy, the disease activity should be monitored at least in each trimester, and more frequently if they have active systemic disease. If a person is not having active disease, she should be assessed by rheumatologist at least once in a trimester. If she's having some active disease, then it should be monthly. Laboratory testing is very important in whether the patient is having active disease or inactive disease. So at the initial visit, as soon as the pregnancy is confirmed, there should be thorough physical examination, check of blood pressure, obviously, and renal functions should be seen, complete blood test, and liver functions, and autoantibodies, including anti-Ro, anti-La antibodies should be checked, if not checked previously, to detect presence of antiphospholipid antibody syndrome. And there should be the anti-DNA, anti-dsDNA should be checked, and complement levels should be checked. And these tests should be done in each visit during pregnancy. It includes CBC, creatinine, urinalysis with the urinary sediment, which is very important to differentiate between preeclampsia and lupus nephritis. And spot urinary protein creatinine ratio should be done. And then if a person is having active disease, or you suspect the patient is having flare, then we should check for anti-dsDNA antibodies and complement levels. Rising anti-dsDNA antibody levels and the trend of decreasing complement levels will help us to differentiate whether it's active SLE flare or the pregnancy-related symptoms. Maternal fetal monitoring should be done like the first trimester ultrasound should be done to establish the EDD, and then fetal anatomic survey should be done at 18 weeks. The ultrasonogram evaluation of fetal growth and placental insufficiency in the third trimester should be done. And then the frequency of surveillance usually depends upon case to case. It depends upon the obstetrician and the rheumatologist to see, like, if a patient is high risk, that frequency of the monitoring can be more, and it depends upon them. But generally, every 4 week, the patient should be should undergo evaluation by obstetrician. So in a patient with the positivity of anti-Ro and anti-La antibodies, the congenital heart block check should be done. And it's recommended to start from the 18th week to do fetal echocardiogram. So now we will come to the pharmacological management of SLE during pregnancy. So the recommended during pregnancy, as soon as the pregnancy is confirmed, the patient should be on hydroxychloroquine and low dose aspirin. Then glucocorticoid, azathioprine, and cyclosporin and tacrolimus can be used during pregnancy safely. Uh, Biologicals are avoided in pregnancy because of the teratogenic effects. So if a patient is having life-threatening condition, then the drugs counter the number 3 and number 4 actually usually fall in the same category. So if a person is having life-threatening condition, after proper discussion with the patient, we can use that, but they are contraindicated. It includes biological agents like rituximab, belimumab, BAFF inhibitor, cyclophosphamide, mycophenolate, and methotrexate, and leflunomide. Hydroxychloroquine is recommended in pregnancy, and it helps to reduce the disease flare. It also helps to uh, prevent the congenital heart blocks in the fetus. Low dose aspirin is also is recommended during the pregnancy, and it should be started around 12 week, and it reduces the risk of preeclampsia. Glucocorticoids can be used, but with the minimal possible dose, the dose should be ideally around 10 milligram. Azathioprine can be safely used, and dose should not exceed 2 milligram. Same like cyclosporin and tacrolimus can be used. Uh, Cyclophosphamide is contraindicated in pregnancy, and cyclophosphamide should also be discontinued at least 3 months before conception. And same like methotrexate is also contraindicated, and it should be discontinued 3 months before conception. And mycophenolate should be discontinued about 1.5 to 3 months before conception. Now, certain special consideration of during pregnancy is preeclampsia. Preeclampsia is very common in lupus pregnancy. So it's the patients are more prone to have preeclampsia, the having SLE. So the presentation is usually hypertension, proteinuria, and organ dysfunction after 20 weeks of gestation. And low dose aspirin has been shown to reduce the incidence of preeclampsia by 2 to 5%. And then lupus nephritis. Women with active lupus nephritis should be encouraged to delay the pregnancy until the disease is controlled. A study was done in 193 pregnancies. The women who had active lupus were associated with poor fetal and maternal outcomes. Women with SLE who have received renal transplant, the pregnancy outcomes are similar to the general population who have renal transplant. So the lupus nephritis, how to differentiate between lupus nephritis and preeclampsia? Because basically the symptomatology sometimes overlaps. So we should be able to differentiate between them. Lupus nephritis flares are common and it can mimic preeclampsia. So, or both lupus nephritis and preeclampsia can be there at the same time. So lupus nephritis is usually associated with proteinuria and an active urine sediment. Like red or white cell cast or cellular cast can be there if a person is having lupus nephritis flare. Whereas only proteinuria is seen in preeclampsia, we can't see any active urine cast. Flare of SLE are associated with low and decreasing complement levels. Now, as I explained before, the complement levels are checked before pregnancy and during pregnancy. Even if it's in the normal, but the trend of complement levels can tell us better whether it's SLE or it's a preeclampsia. Then thrombocytopenia, elevated LFTs, and elevated or rising uric acid are more prominent in preeclampsia than lupus nephritis. Uh, the onset of symptoms before 20 weeks of gestation is usually consistent with lupus nephritis rather than preeclampsia. Then finally, the confirmatory test can be done on renal biopsy to differentiate between these two conditions. But because of the pregnancy, it has also limited value. There are multiple complications associated with that. So in SLE patient, there can be antiphospholipid antibodies positive. So if we found that the patient is having antiphospholipid antibody positive, then we should start on aspirin and low molecular weight heparin those cases, because presence of antiphospholipid antibodies are more prone to the patient can more prone to have a miscarriage or fetal loss. Presence of anti-Ro and anti-La antibodies are usually increases the risk of developing congenital complete heart block in the neonatus, or the risk of increased neonatal lupus in the fetus. So the monitoring should be started from 18 to 24 week for detection of any congenital heart abnormality or any heart block. And actually, there is no proper therapeutic intervention to delay, to prevent, to delay to treat the heart block in the uterus. But usually steroids are given if we detect first or second degree heart block. But as I stated before, hydroxychloroquine decreases the risk of developing heart blocks in women who have anti-Ro and anti-La antibodies. And secondly, the breastfeeding can be safely done in the women who have anti-Ro and anti-La antibodies, because they may have detectable amount in the breast milk, but there is no evidence that neonatal lupus can be there in a baby who is breastfeeding on a mother who has anti-Ro and anti-La antibodies positive. Then finally, breastfeeding is encouraged for the woman who has SLE. Hydroxychloroquine, prednisolone, cyclosporin, and azathioprine and tacrolimus can be safely given during the breastfeeding. Methotrexate, mycophenolate, and cyclophosphamide and leflunomide are discouraged. They are not compatible with the breastfeeding. And biologics are minimally secreted in the breast milk. So there is studies which have shown that it's minimally secreted in the breast milk. So some studies suggest that it can be given during the breastfeeding. But generally, since it's avoided in the pregnancy, so generally we should avoid breastfeeding if a mother is on biologic. These are my references for today's presentation. Thank you.